you're having chest pain, please notify the triage nurse. And of course, it's also in Spanish. The problem is, people come in and see that the waiting room is full, and they say, oh, I'm having chest pain, and my ankle hurts. So they think they're going to get back quickly because they say they have a chest pain, but really they're there because they have an ankle sprain or they got this rash. But they'll start off saying, I'm having chest pain because they see that sign. So the triage nurse has to deal with that. If they say, I'm having chest pain, the triage nurse has to deal with that. And it's really clogging up our units. It really is. People are making up BS chest pain just in order to get back and be seen. So we need to have a really good way to evaluate chest pain, and that's kind of what this first hour is all about, is how to evaluate the chest pain. I worked at OU Thompson for 13 years. Before that, I was at Hillcrest. Before that, I was in worked up a whole bunch of chest pains. So this is the sign that's in every ER across the country in this illness. When we're doing a workup for chest pain, you need to do a quick history. One of the mnemonics that I use, again, one of the mnemonics that I use is PQR star. It works really well for chest pain, but you can also use it anytime you're just interviewing anybody who's got a complaint. The P stands for palliative and provocative. What makes it better, what makes it worse. In the terms of chest pain, if they say it's worse if I exert myself and it's better if I rest, that's pretty telling. Or if they say it's worse if I eat Ted's for lunch, better if I take my Lantus, that's kind of telling too. So the PQR star, the P is palliative provocative. What makes it better, what makes it worse. The Q is quality. What kind of pain is it? What is it? Is it sharp pain? Is it dull pain? Is it heaviness? Is it a ripping sensation? That's important. The R is radiation. Where does it radiate to? PQR, radiation. Does it go into the arm? With chest pain, it's important. Does it go into the elbow, into the arm? Does it go up the neck and into the jaw? You know, MIs can frequently show up with the jaw pain. So that's part of the PQR star. The S is severity. How severe is it on a scale of 1 to 10? And how severe was it when it started? How severe is it now? How severe has it been in the interim? Kind of get a timeline for the severity. Then the T is timing. When did it start? What were they doing? It's important to know if he was the old classic shoveling snow when the chest pain started. That's pretty demanding as opposed to somebody just sitting there watching TV. The A in PQRS star is associations. With chest pain, you want to know is associated with nausea, vomiting, shortness of breath, diaphoresis, all those types of things that are kind of telling for somebody that's got chest pain. The R in the mnemonic is risk factors. Do they smoke? Do they have diabetes? Do they have hypertension? Do they have a family history of heart disease? Things like that. You can do the same thing with abdominal pain, with any kind of complaint they come in with. If you use the PQR star mnemonic, it'll help a lot. So first off, we're going to start with the history. Another mnemonic I use is, I should just write this down. Yeah, FARMS. It's F-A-R-M-M-S-S. F-A-R-M-M-S-S. This is the most used mnemonic in my practice, and all the PA students that rotated with me said this is the one they use the most too. And it's just real simple. You need to get a FARMS on everybody. I tell my students that make sure you get the FARMS. The FARMS is the family history, of allergies, review of systems, past medical history, medications, surgical history, social history. You got to get that on every single person, the FARMS. Especially just to get paid. You need to have that stuff on your chart to make sure you get paid, but it really helps when you're evaluating a patient to know the FARMS. So that's a unique mnemonic to me, but I've trained so many PAs that just about everybody knows if you say FARMS, they know what you're talking about. Palliative, provocative, quality, radiation, severity, and all this is on there. Associations, risks. Be sure and get the vital signs anytime you're working up a chest pain patient, and then you got to do a physical, right? Specifically, you want to listen to their heart, you want to listen to their lungs, do a quick HCNT, check their abdomen, check their legs, look at their back. Need to get an EKG. You guys have all had EKG, right? Everybody feel comfortable reading EKGs? I can come in for 3 hours, Dr. McNeil, and make them experts in EKGs in 3 hours. If you're
Yes, yes, yes.
you want to get a chest X-ray. It's just something that goes with the workout. All right? So we're going to do, I think, 6 cases here. Here's the first case. Typical ER patient, 62-year-old man. comes in saying, I'm having chest pain. So they'll go through the workup. His past medical history's got diabetes, failure to provocative, it gets worse with exertion, it gets better with rest. He describes it as a dull pain. Radiation, it goes to his left arm, into his back, into his jaw. Severity is 8 out of 10. Timing, it started early tonight after dinner while he's watching Desperate Housewives on TV. He's got some nausea but no vomiting, some shortness of breath. Thinks it might have broke out into a sweat, he's not sure. Risk factors, he's got diabetes, he is a smoker, and he has a family history for heart disease. All right? This is vital signs, 146/92, heart rate's 108, respiration 16, pulse ox is 98%, and he's afebrile. Physical exam is essentially negative. I'm not going to go through a whole exam, but it's essentially negative. His heart. Are you comfortable listening to heart sounds and no one murmurs? Figure those out. Some say yes, some say so-so. Most say no. It's like, let me take just like two minutes and show you something that I came up with that I came up with this to help me. And it turned out to help a lot of case students with it as well. One hand clapping. This is the sound that a valve makes when it closes. Okay? It doesn't make a sound when it opens. A valve does not make a sound when it opens. It makes a sound when it closes. Okay? That's the first part. So everybody do this. Hold up your thumb and say love. Love. Put your thumb down and put your little finger out. Duh. So it goes like this. Love, duh. Love, duh. Love, duh. Love. Love, this is the aortic valve and the pulmonic valve. Going straight up off the heart, and it's open. Love was made by the sound of the AV valves, the mitral and the tricuspid valves closing, right? So love is like this. Duh is this valve closing, the aortic and the pulmonic valves closing, and the AV valves open. So we're hearing this close for duh. So it's love, duh, love, duh. Now look at this. Love. Between love and duh is systole, right? That's systole. That's when you can feel the pulse. If you're not sure where's love and where's the duh, feel the pulse. When you're feeling the pulse, that's the love. So here's what's cool. If you hear a murmur in systole, it's going to be between the love and the duh. So it's going to be love, shh, duh. Love, shh, duh. Love, shh, duh. Love, shh. So what's making that murmur? There's only 4 options to making that murmur. These valves are open, right? If a valve is open and it's going to make a murmur, it's stenosis. So if we hear a murmur in systole in this position, it's either aortic stenosis or pulmonary stenosis, right? If a valve is closed and it's making noise, it's insufficiency or regurgitation. That's the same thing. So it's either, if you're a systolic murmur in the love, it's either aortic stenosis or pulmonic stenosis because this valve is open, or it's mitral regurg or tricuspid regurg because these are closed. Duh. Love, duh, shh. Love, duh, shh. Now we're hearing a murmur in diastole. In diastole, this is open. So it's either mitral stenosis, tricuspid stenosis, or these valves are closed, aortic regurg or pulmonary regurg. Doesn't that make it a whole lot easier? Now you just got to say where do you hear the best? You're here, atrial, aortic, pulmonic, tricuspid. So if I tell you have a systolic murmur, and it's heard best in the P region, what is it? Pulmonary stenosis, because this valve is open, that's the one. So that's a tangent. I don't hear one. All right, there's his EKG. Anybody see anything that worries them? It looks like an MI to me. Got this down, segment elevation, V2, V3, V4. There's some reciprocal changes. There's a chest x-ray. So, looks like it's having an MI, right? We're going to do the standard MI treatment, and give them aspirin, nitro, maybe thrombolytics, maybe beta blockers, heparin, maybe go to the cath lab. It depends on what the cardiologist is on duty and his particular likes and dislikes. All right, everybody good with case one? Case two. It's this guy. It's a 48-year-old guy with chest pain. Palliative provocative, nothing makes his pain better or worse. Quality, it's a dull, gripping, ripping, sharp type of pain. Radiates to his left neck, into his back, and into his jaw. Severity is 10 out of 10. Timing, started at 6:42. Exactly 6:42. That's kind of important. Not because it's 6:42 and even because it's an exact time. If they can tell you an exact time, that's kind of telling. Associations, he's got nausea and vomiting and no shortness of breath. Nausea, vomiting, but no shortness of breath. Some diaphoresis, maybe. Risk factors, he's diabetic. He's a smoker and he's got a family history. Vital signs, a little bit hypertensive, 168/106, a little bit tachycardic, 121, respiratory rate is 16, pulse ox is 99, and he is afebrile. His physical exam is essentially negative. We'll tell you this guy's about 6'7". I really did take care of this guy. He's about 6'7". Everybody knows what that is? Diastolic murmur. So diastole, it's here, it's like this. So it's either aortic or pulmonic regurg, which you would hear up here, or it's tricuspid stenosis. You just kind of decide, where do you hear it best? There's his issue. Any brave souls? Second inferior wall MI is ST elevation in 2, 3, and F. With reciprocal changes in V2 and V2 and V3. All right, so he's having an inferior wall MI. We're going to give him aspirin, nitro, thrombolytics, beta blockers, cath lab, whatever we pick for him. Everybody okay with that? No, don't be okay with that. We didn't do a chest X-ray. Remember I told you he's 6'7"? He's got a high arched palate. Turns out he's got Marfan syndrome. He didn't know. We diagnosed him. Got a high arched palate. This was his X-ray. Got a widened mediastinum. He happened to have an X-ray 3 months prior, which showed that, and now he's got the widened mediastinum. Marfan syndrome or Ehlers-Danlos syndrome is another condition that can cause aortic dissection. They can have, with Ehlers-Danlos, they have rubber skin. They just pull it, and they also have really, really mobile joints that can take their thumb and bend it all the way back and all kinds of weird things. But those people are predisposed to aortic dissections. So what's an aortic dissection? I'm sure you know this, but the blood gets out of the normal canal and the lumen of the vessel and starts tracking down the side. And this guy's dissection is right at the root of the aorta. So as the dissection advances, it's nicking off the coronary arteries. So this is a really, really big deal. What are we going to do for him? It's not what we said. We're not going to take him to the cath lab and give him the aspirin and heparin and hope he does better. He needs a graft. He's got to go to surgery for that. This was, when I saw this guy, it was about 30 years ago. Nobody in Oklahoma City was doing it. And so I just started calling and finally found somebody in Houston who was doing debating. And we loaded him up on an airplane and on a private jet and sent him to Houston. And he came back later and thanked me for it. Kind of a cool case, really. All right, third case. It's a working woman. She's 38 years old. She comes into the ER with chest pain. Nothing makes it better, nothing makes it worse. It's a sharp pain, doesn't radiate, 7 out of 10. It's been going on for about 2 days. It does have some shortness of breath. She is a smoker. Let's see, 140/90, heart rate is 134, respirations are 20, pulse ox 97. Oh, look, she got a temperature of 102.4. Don't hear any murmurs. I think that maybe a split 1, but here's her EKG. Anything abnormal there? QA where?
3 ABM.
Yes, there was QAs and 3 ABM. Are we gonna, can we put anything to that? Here's her chest x-ray. Looks like she has a little pneumonia. She had a temperature of 102. She was hypoxic. So, put her on some antibiotics. Everybody okay with that? Oh, okay with that. What is it called? Fleischner's lines. You see that with pulmonary embolism. With pulmonary embolism, you can see something called Hampton's hump if they actually progress onto a pulmonary infarct. Pulmonary embolisms frequently will have a fever, tachycardia. Additional history, turns out she just got off a Greyhound bus. She came up from Nashville, Tennessee, and finally got around to doing a real physical exam and found she had DVTs. Her left calf was swollen and tender. So she had a DVT and a pulmonary embolism. So it's a totally different story now. And her EKG actually does show a pattern for PE. You guys know the pattern for PE? It's S1Q3T3. And that's wave in lead 1, which means it's just a really tall QRS with a deep slurred S. A Q wave in 3 and an inverted T in 3. S1Q3T3. The worse the PE is, the more inverted T waves are going to have across the precordial. So more and more flip Ts is a worse and a bad prognosticator for PE. Those are called Fleischner's lines. Don't let me suck you in like that. It's a thing called Wells criteria. Just you can basically predict the probability of pulmonary embolism based on these findings. You can also get an ABG. If you're suspicious for a PE, you can get an ABG. Now there's a bit of a caveat there. If you got somebody that you can't decide do they have a PE, do they have an infarct, so you stick a needle in their radial artery to get an ABG, and later on we decide, well, their cardiac enzymes are back and it's a myocardial infarction. Now, you really want to give them thrombolytics, they got a hole in the radial artery. That's kind of a no-brainer. I probably wouldn't want to have a hole in my radial artery and then get thrombolytics. But if you think it's a PE, you can get an ABG. And you can do what's called a AA gradient. And the formula is 150 minus 1.2 times the PCO2 minus the PO2. 150 minus 1.2 times the PCO2 minus the PO2. That should be 15 or less. If it gets up to 30 or 40, you probably got a PE. All right? That formula is specific for sea level. Oklahoma City is at sea level. The formula has to be jacked around with if you go to Denver, Colorado, or something like that. But if you're working in Oklahoma, if you're working anywhere at the sea level, that's the formula that you can use. You can also get a D-dimer. D-dimer is getting to be more and more sensitive for blood clots and PEs. But not every hospital can get a D-dimer back quickly. You can always get an ABG back quickly. The other caveat, besides it has to be at sea level, it has to be roommated. The patient can't be on oxygen, so it has to be on roommate. So that's another kind of a bad thing. You have to take them off their oxygen for a while before you get the ABG. Questions about that? You guys heard that before? Okay. All right, this is a 22-year-old female. She's coming in with chest pain. She says it's positional. It hurts more when I do this or when I lean forward or whatever. It's sharp pain. Doesn't radiate anywhere. It's 5 out of 10. It's been going on for 3 days. She does have some shortness of breath. I think it's more that it hurts to breathe, but she calls it shortness of breath. Doesn't have any risk factors at all. 110/70, heart rate's 110, respiration 16, pulse ox is 98%. She's afebrile. Physical exam is really pretty normal. Here's her EKG. Did I say anything abnormal? Moving on. There's her. It's an EKG that shows pericarditis. She's got ST elevation everywhere. She got it in V2, V3, V4, V5, V6, and 1, and 2, and 3, and L, and F. Only in R and V1 do you not see ST elevation. That's kind of classic for somebody with pericarditis. The other thing that you'll hear in the next lecture is, well, I'll say it for the next lecture. The problem with pericarditis is we usually just send them home, but they can develop a pleural effusion, a cardiac effusion, and develop a cardiac tamponade. So, in the ER, we have to get an ultrasound to make sure that they don't have pericardial effusion. And that's what I was talking with Doc about. I used to do a kind of an ultrasound workshop to show you how to find a pericardial effusion, how to find a section in aortic aneurysm, things like that. Hopefully we can do that later. And how to do what's called a FAST exam. A FAST exam is it's a really quick, it's like a 1-minute exam that looks at both kidneys, the liver, and the bladder to see if anybody has intra-abdominal bleeding secondary to trauma. So we worry about this girl's developing a pericardial effusion and it getting bigger. So you got to at least get an ultrasound, make sure she didn't develop into something like this. If you get a pericardial effusion that gets way too big, way too fast, you get a cardiac tamponade. If she doesn't have that, then she gets NSAIDs, typically gets admitted, gets NSAIDs. This is a plant called colchicum, from which we get colchicine. And colchicine has been found to help with pericarditis as well. If it does get into tamponade, everybody know what Bextriad is? Right. Bextriad, muffled heart tones, hypotension, JVD. Goes along with tamponade. They'll also have, on the monitor on your EKG, they'll have what's called the electrical ultrasounds. Remember, the heart is beating in a bag of waters, basically. So the QRSs are variable. Sometimes they'll be tall, sometimes they'll be small, sometimes they'll be medium, to back and forth and back and forth. That's called electrical alternates. Another sign, along with Bextriad, that your patient may have a cardiac tamponade, and this is a pericardiocentesis to relieve that. Done a ton of those. All right, case 5. It's a 43-year-old male with chest pain. Nothing makes it better, nothing makes it worse. He describes it as an elephant standing on his chest. It doesn't radiate anywhere. It's 9 out of 10. It's been going on for about 3 hours. Some shortness of breath, some nausea and vomiting. He does have a history of hypertension.
Oh.
90/50. Heart rate's 92, respiration is 14, pulse ox 100, and he's afebrile. Physical exam. What's that? Is it S3? Something that might be an S3. There's certainly no murmurs there. On exam, he's got an edema. On EKG, he's got what? Where? Right, ST elevation in 2, 3, and F. So what is it? Inferior wall MI. So he's got an inferior wall MI, right? He's got signs and symptoms of CHF. He's got shortness of breath, and he's got hidden edema in his feet and ankles. There's his chest X-ray. So, what are we going to do with him? He's got an inferior wall MI. He's got CHF. He's a little bit hypotensive. We do the standard treatment that we do for inferior wall MI. But this is something you probably haven't heard, but you need to hear. You need to do a right-sided lead. anytime somebody with an inferior wall MI comes in, especially with signs of CHF, you gotta worry about right ventricular failure. Usually it's left ventricular failure, but you gotta worry about right ventricular infarct. And the way we do that is, your V leads go like this: V1, V2, V3, V4, V5. Take V4 right here over the left nipple, and put it on the right nipple. And now look, do another EKG. Be sure to label it. This is right-sided V4, RV4. Label it. If you see ST elevation there, you've got a right ventricular infarct. Another key that's just recently come to light is, as you're looking at the EKG, if the ST elevation in lead 3 is greater than it is in lead 2, that's also a sign that it may be right ventricular. But why is that important? Why do you care if it's left heart or right heart? The reason it's important is, even though this guy looks like he's drowning, his x-ray is horrible, he's got pitting edema, he's short of breath, he needs more fluids. He needs more IV fluids. And the reason is the right heart's not working, you have to kind of prime the pump. So even though it's counterintuitive, it looks like he's drowning, you need to order a liter of normal saline. 19-year-old female with chest pain. Nothing makes it better and nothing makes it worse. Sharp pain, non-radiating, 4 out of 10. Started yesterday. She's already been to one doc. He told her she was anxious. She does have some anxiety. She also got some shortness of breath associated with this. She doesn't really have any risk factors at all. 110 over 80, heart rate's 112, respiration 16, pulse ox is 96, she's afebrile. Physical exam is essentially normal. She does seem to have some chest wall pain when you poke her. Not going to do a chest x-ray because she said she might be pregnant. So we're going to think she's got a chest wall pain. Not even going to do an EKG. Bad, just don't do that. Just because she thinks she might be pregnant doesn't mean you can't do a chest x-ray. Put a pelvic shield on. Put a pelvic shield and do the x-ray because she's got a pneumothorax. I saw about 3 every year that I practiced. It was almost always 19-year-old girls who come from another ER. And the other guy did not do the x-ray. And I did the x-ray and found it. I don't know why. These 19-year-old girls run around with pneumothorax, but now I get to be the star because I'm the one that found it. I'm the best doctor in the world, and that other guy is just a horrible guy. So I got a couple examples of pneumothorax for you. It's really, really subtle sometimes. That was not so subtle. All right, case 6. What are we going to do for her? If it's a big enough pneumothorax, she's going to get a chest tube. Case 7. 46-year-old male with chest pain. Nothing makes it better, nothing makes it worse. He describes it as a burning and a tearing. That's different from what we've heard before. It kind of radiates into his epigastrium. Maybe it starts in his epigastrium, he's not sure. He rates it 10 out of 10. And he doesn't look like a squirrel. He really thinks it's 10 out of 10. He kind of looks sick. Timing just started tonight after dinner, associated with quite a bit of vomiting. He is alcoholic and he's overweight. 90 over 40. Heart rate's 124, respiration 16. Pulse ox is 100, and he's afebrile. Physical exam, this guy just looks sick. He's very tender in the epigastrium. He's got some subcutaneous emphysemas. You know what that means? It feels like Rice Krispies under his skin. Just push all over. You see that with pneumothorax a lot. Maybe he's got a pneumothorax. EKG is normal. You all recognize that, right? Everybody recognizes that. That's microwave popcorn. That's what his heart sounds like. It really does sound like microwave popcorn. I'll play it again just to make sure you know what microwave popcorn sounds like. It's called Hammond's Crunch. There's his is X-ray. The subcutaneous emphysema and hearing Hammond's crunch, which goes along with esophageal ruptures. We get a barium swallow on it. And you can see you've got an esophageal rupture. These people are going to die if they don't get to the operating room right away and get antibiotics and get supportive care. This is really, really a bad thing. Boerhaave syndrome associated with esophageal rupture. It's usually secondary to something like this, just really, really retching, severe retching, and you can rupture your esophagus. Mackler's triad is vomiting with lower thorax pain and subcutaneous air. Kind of a hint of esophageal rupture. I'm going to skip this stuff. All right, any questions about that? Okay, go to the next one. This is a really, really long lecture I put together about EKGs. I did it for one of the medical conferences. I don't know if it was a PA conference or an MD or a DO conference. But I'm not going to give you the whole thing. I'm going to give you the most important parts. Because we only got 30 minutes. Right, 10 things not to be missed. Most of these are really subtle findings. And this last stem here, how did I last this long? For real, how did I last this long? Some of these things I just learned last year, and I should have known them all along. I can't believe I didn't get burned, I didn't get sued, and I didn't kill somebody. So thank God I learned it now, and I want to pass it on to you. I know you guys saw when I was trying to find the right place, you saw what this is. This is somebody who passed out and I feel better now. What's wrong with her? Passed out, but I feel better now. I'll show you another example. If you don't see it there, I'll show you another example. Here's another one. Passed out, I feel better now. Oh, I have a headache too. That's a subarachnoid bleed. See the bat wings? Yesterday was not that far away. Here's another example. This is the bat wing. Subarachnoid bleed. Please don't miss that. The subarachnoid bleed on PET scan. That's not so subtle, but I got some ones that are over subtle. All right, I had a pepperoni pizza and I don't feel very well now. What's wrong with this guy? Somebody said MI. It's an inferior wall MI, right? ST elevation 2, 3, and F with some reciprocal changes. If he's got CHF, what are we going to do? Right-sided V4. Take V4 that's on the left, put it on the right, look for 1 millimeter of ST segment elevation to make sure it didn't have a right ventricular infarct, which would change treatment. RV4. Just some literature about that. Right ventricular infarction complicates up to 40% of inferior stents. Also, let's see the last 2 lines there. Hypertension and right ventricular infarction treated with fluid loading, despite the fact that they look like they're in failure, and nitrates are contraindicated. So it's really important to know if it's the right ventricle. The last paragraph here shows what I said earlier. ST elevation in lead 3 is greater than the ST elevation in lead 2. That should be your first thought that maybe this is a right ventricular infarct. And if you see ST elevation in V1, that also hints that it may be right ventricular. But most useful is right-sided V4. All right? So look at this one. This is inferior infarct. Look at 2, 3, and F. There's ST elevation in 2, 3, and F. There's ST elevation in V1. which also indicates this may be a right-sided infarct. And look at the ST elevation in lead 3. It's greater than the ST elevation that is in lead 2. All of those things make you think this is a right ventricular infarction, not a left ventricular infarction. And then this is when we took RV4 and moved it, and you can see ST elevation in RV4. This is the right side. This is the one that we didn't move. Look at RV4. Look at V4, it's normal. And then when we flipped it over to the right side, you got ST elevation. So it's really important to know that. You'd be amazed how many people do not know that. Here's another one, ST elevation in 2, 3, and F. ST elevation is greater in 3 than it is in 2. That's kind of a signal. There is ST elevation in V1. That's kind of a signal. And then down here below, RV4, there is ST elevation in right side of V4. And this one they did right side of leads. They just flipped everything, but you really don't have to. You just need to put in V4 and move it. You don't have to move all of the V leads. All right. Patient comes in and says, I just don't feel good. What is wrong with her? Look at those T waves. T waves, it's almost like upside down bat wing T waves. Super, super tall. This is somebody who's got acute renal failure. It's hyperkalemia. This is a guy who comes in and says, I think I'm having a panic attack. And give him some Valium and send him home. See, he has an anterolateral ST elevation. He's got the whole anterior wall of his heart is infarcted. ST elevation V1, 2, 3, 4, 5, 6. Also lead 1 with reciprocal changes just about everywhere else. Remember, the normal adult EKG, the majority of the QRS complexes are positive. They have tall R waves. And the T wave in V1 should be really small and flat. If you have a tall T wave in V1, you're worried about an early sign of infarction. Heart racing, but I feel okay now. I would be really surprised if you get this because I can't really see it. I know what it is, but I can't really see it. Look at the V leads. Kind of a slurring of the QRS. It's called WPW, or Parkinson-White. You've studied that, right?
Mm-hmm.
So it's got a slurring of the QRS, which makes a false prolongation of the QRS and a false shortening of the PR. It can go on to become supraventricular tachycardia. If you have somebody with WPW and they have a supraventricular tachycardia, what medicine are you going to use to treat it? Most people say lidocaine, but the answer is right in front of you. It's the P and WPW, procaine. It's not old Parkinson, it's old procaine. Anyway. Procainamide. All right, this lady said, I just fainted. I feel fine now. Here's her EKG. This is kind of a subtle finding. When I show you, you're going to say, oh yeah. Anybody want to jump out and be a star? It's a prolonged QT. Prolonged QT is due to drugs or low calcium, hypocalcemia. It can go on to become a supraventricular tachycardia, ETAC. It can cause all kinds of problems. The thing to remember is that the QT is a calculated measurement. It's calculated based on the heart rate. So if your heart rate is 150, the normal QT is going to be different than if your heart rate is 100. And the QT is going to be different if your heart rate is 50. But for the most part, just for the most part, you can say the QT shouldn't be longer than 2 boxes. And that has been so handy for me. So if you just find a QRS that is on one of the big bold lines like this one here, and then count over 2 boxes. 1, 2. The QT is done before the second box, so that's okay. By the same, here's a long one. Here's one that's on the big box. 1, 2, you still got a T wave going, it's almost 3 boxes long, that's prolonged QT. It's really kind of generic, it's kind of holding up your thumb, but man, it really does work good. By the same token, if it's less than 1 box, it's probably a short QT. We don't go out and tell everybody, well, it's just got to be 2 boxes, because remember, it's got to be calculated based on the weight. So you should know what this one is, because we just talked about it. Uzi, I feel okay now. This is a short QT. See, the T is just right there. It comes right after the QRS. That's a short QT. Short QT syndrome. It can go to VTAC, syncope, and sudden cardiac death. It's from hypercalcemia. People get them all mixed up. Too much calcium does what, and too low calcium does what. The way I remember it is hypocalcemia. Hypocalcemia causes hyper QT. And hypercalcemia causes a hypo QT. All right, here's a signature EKG. This is one of those ones that you just don't ever want to miss. He's a weekend warrior. Weekend warrior is the guy that does nothing but sit on his butt all day in the office, and then on the weekends he's a basketball player and a softball player, and he goes out and he just goes crazy. So he comes in on a Sunday and said he passed out, but he feels okay now. Does anybody know this? This is one that you just can't afford to miss. You have to know this. Here's some of the keys. They're down here, and these are supposed to be spinning. I guess they are. Kind of got a deep Q, kind of got a tall R, and then some ST segment depression, usually in V5 and V6. This is arrhythmogenic right ventricular cardiomyopathy. This is like a thumbprint. This is a blueprint. Arrhythmogenic right ventricular cardiomyopathy. Oh, sorry, it's hypertrophic cardiomyopathy. I got ahead of myself. This is hypertrophic cardiomyopathy. So it's got deep flipped T waves, tall R waves, this is all in the V leads, and deep Q waves. Look at V5 and V6. Hypertrophic cardiomyopathy. There's another one. These people, it's kind of weird. They can just have a sudden syncope, they can have sudden angina, sudden palpitations, usually associated with exertion, but when they rest, it just all goes away. And it's due to thickening of the septum. All right, here's another signature EKG. This is one of my favorite ones. One of my 2 favorite ones to teach. Anybody recognize anything bad here? This is actually very, 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 very common. And it's just amazing how many people don't know this and haven't been taught this. I used to teach the EKG course at OU, and all the PA students, they named this, it's not the real name of it, they called it shark fin syndrome. If you look at V2, it looked like a shark fin sticking out of the water, see that? V1 also, called it shark fin syndrome. And every time it would come up, they go, it's Brugada syndrome. You ever heard of it? I guarantee if somebody comes in, and they will, and you miss it, you're going to get sued. You can't miss Brugada syndrome, or as the PA students call it, shark fin syndrome. So I'm going to show you a couple examples of it. In this one, look at V1, which is right here. It's important to know what it is. It's a sodium ion channelopathy, and it predisposes to people to VTAC and DFib. Shark fin syndrome, Brugada. Here's another example. It's almost always in V1, V2, V3. V2 is probably the most common. And when you see that, start going, and think of Brugada's sodium channelopathy. Got it? I want to make sure. There's another one. Brugada's. Got it? I want to make sure. There's another one. Got it?
So what's happening with these patients?
They can go into VFib VTAC. But the problem is with the sodium channels. There's another example, Rugadas, shark fin syndrome. Remember, that's just, the PA students made that up. Don't go on your cardiology rotation and say shark fin syndrome, because they're going to melt you out of the crowd. Call it Rugadas. That's what it's, that's a classic one. It's mostly in B2. If you don't see it in B2, you can see it in B1 or in B3. Remember, the lead placement is typically a high school student or a guy who just graduated from high school working as a tech in the ER. He doesn't always put the leads in the right place. Another one. Rugadas syndrome. All right, so we're done with Rugada. This is my second favorite. No, this is not it. All right, so this is almost passed out and I feel okay now. I'll be totally blown away if anybody knows what this is. This is one of the ones I didn't know last year until I put this lecture together. This is the arrhythmogenic right ventricular dysplasia cardiomyopathy. Now I'll hone in on what's important on the EKG because you most definitely can't see it. I'll show you with my little pointer here. It's right here. See that little nipple on the top of this? Right around the J1. I got better examples here. Call it epsilon wave. I got the next one is that's what we're looking at. How easy would that be to miss? That would be very, very easy to miss. And I suspect in my time I had missed it because I didn't even know about it until last year. But that is really, really a cardinal red flag danger sign. Don't pass somebody's school physical and don't let an MMA fighter or a boxer fight if they've got that on them. Okay, here's another one. I passed out, but I feel okay now. What's this person got? This is kind of a repeat from the last lecture. There's an S wave in 1, Q wave in 3, flip T in 3. There's flip T's everywhere. This is a pulmonary embolism. S1, Q3, T3. This one has a lot of flip T waves. So S wave in 1, a Q wave in 3, and a flip T wave. And you don't have to have S1, Q3, T3, but it's the signature for it. The next couple slides are basically going to say the more T waves that are flipped, the worse the PE is. And scientific studies are starting to prove that now. If you guys familiar with a PE, you know they got a PE. Look at their EKG. If they got a whole bunch of flipped T waves, it's going to be a bad PE. All right, here's somebody with severe shortness of breath. This is a condition we talked about in the last lecture. I'd be curious if anybody picks it up now. I'll wait 10 seconds and then I'll put up a little bit.
Effusion.
What is it?
Effusion. Effusion.
Yes. That is good. If you said what I think you said. Did you say effusion? Yeah. This is electrical alternators. Look right here. Look, there's a QRS that is up. There's one that's down. There's one that's kind of middle. There's one that's down. That's the electrical alternators. Pericardial effusion. Guess you buy her lunch. So you worry about that because it can go on and be tampered. All right, another signature EKG. I had chest pain, but I'm okay now. For me, this is right up there with Rugadas. This is one you just have to know. What we're looking at is V2 and V3. It looks like this looks like a Z, and this looks like a Z. So the students all called it ZZ top syndrome. ZZ top syndrome. Anybody know what that is? Don't go in your rotations and say ZZ top syndrome. That's where we got shark fin for Rugada. We got ZZ top syndrome for Wellenstein. Have you heard of that? Wellenstein. Here's another good example of it. Look at V2. V2 and V3. It's like two Z's. ZZ. You know, if you didn't know to look for that, you just kind of overlooked that. You just kind of write that off as something that's just kind of trivial and maybe a normal variant. But that's huge. It's associated with a critical proximal LAD. And listen, get this. It typically happens when they're pain-free. So you're in the ER and somebody comes in with chest pain, and the nurse comes in and says, I go over there and 5's got chest pain. Quick, get an EKG. Now you missed it. But Wellens sign is when they're not having it. Isn't that weird? And it's very dynamic. It comes and goes. Here's another example of it. Wellens sign. They also call it Wellens warning. Either way, but it just ZZ top is the way I remember it. Shark fin for Brugada. That's a sodium channel ion problem, and ZZ top for Wellens warning. There's another one, Wellens sign. Everybody see that, right? This is actually ZZZ. There's 3 of them. Everybody see it? V2, V3. Right here. There's another one. And look at this one. I think this is really cool. Wellens sign, no Wellens sign. Wellens sign, no Wellens sign. It literally changes beat to beat. So not only do you have to know to look for this, but then you have to be lucky enough to catch it. But it's so important. So here's another one. This one's not quite as pronounced, but I think it's there. I got time up there to ask you, when is the worst time to have a heart attack? Late July, mid-August, early August, because that's when the new med students have become interns, residents, and cardiology fellows, and I think they know everything. I had this EKG, and I called, in August, I called the new cardiology fellow and said, I think I have a guy down here with Wellens sign, and he said, what's a Wellens sign? It's the worst time to have a heart attack when the classes are changing. Another example, I just want to make sure you know what we're talking about. Wellens sign or Wellens warning. I have a whole bunch of EKGs. I've got 1,000. And I have no idea what this is all about. I don't know what the case is. I just going through and I said, dang, look at that. There's a Wellens sign. I don't know what happened to the patient. I don't know if he went home. But that's clearly a Wellens sign. Okay, this person's having chest pain. Send them home. Maybe it's just on EKG. Would you send them home? What would be the problem? Look at those T waves. T waves are really, really, really tall. Do you have hyperkalemia? No. Hyperkalemia causes really tall T waves that are pointy. These have a rounded hump on them. These are hyperacute T waves. They're not pointed. They got a broad base at the top. This is somebody getting ready to go. This is somebody who's getting ready to go. Hyperacute T waves like that. Okay, this is a little old lady who came in and said, I had some chest pain, but I feel okay now. This is her EKG. I'll just go through it quickly because I think we're running out of time for this second. Look at V1. There's kind of a tall T wave in V1. You probably wouldn't get excited about that, and I might not get excited about that, but I know you're not supposed to have almost any T wave in V1 at all. Any upright T wave in V1. We did find an EKG from before, 1 week ago. Look at her V1 there. So in 1 week, she's developed a T wave. She's getting ready to have some serious cardiac events. And also notice that in the V leads, she's starting to get some hyperacute T waves. They're not pointy like hyperkalemia. They're broad like hyperacute T wave and getting ready to die. Another example, if you see a tall T wave in V1, that may be the earliest indicator that somebody's getting ready to have a heart attack. All right, this is somebody with chest pain. We're almost 15 minutes. This person has ST elevation in the V1. We're not supposed to see even a T wave in V1. Really, this person has ST elevation in V1. But we're also going to look at AVR. AVR is kind of the orphan lead. Nobody looks at AVR for anything. But you should. I'm getting ready to show you a bunch of things that go with AVR. AVR should have normally a PR that's on baseline and an ST that's on baseline. Okay? So here's the magic of AVR. We're just going to look at AVR. I bet you've never been taught to look at AVR for anything. 4 things we're going to look at for AVR. ST segment elevation in AVR suggests left main obstruction. Who knew? Again, I just learned this last year. ST segment elevation in AVR, suggestive of left main obstruction. PR segment elevation in AVR, suggestive of acute pericarditis. I went back and looked at all of my EKGs that I've got with pericarditis that I used to teach, and sure enough, every one of them had PR elevation in AVR. I didn't know to look for it when I was teaching that, but they do. They've got it. If you have a R prime, like this, so rabbit ears, if you got little rabbit ears, that's probably somebody who took tricyclic overdose. Man, that's a ton of information just from one little lead. One little lead that's really kind of going backwards, AVR. And last, if you have ST segment elevation in the face of tachycardia, it suggests an AV reentry tachycardia. That's a lot of good stuff about AVR right there. So look at this one. AVR has got an R prime. It's got a wide QRS and sinus tachycardia. Those are all the hallmarks of tricyclic overdose. Tachycardia, widened QRS, and now an R prime and AVR. Another tricyclic overdose, R prime and RVR, plenty of years in RVR. Widened QRS and tachycardia, another tricyclic overdose. I had pain, but I'm okay now. AVR's got, looks like some PR elevation. There's also ST elevation everywhere. Just pericarditis. I feel weak. Anybody know why this patient feels weak? Look at those T waves in the auditorium. Really, really tall, but these are pointy. So you got hyperkalemia. Worried about hyperkalemia. I think this is the last topic. The little lady with chest pain. You're going to send her home based on this EKG, or you're going to put her in? If you're going to put her in, why would you put her in? Anybody know what this is? Let me go back a little bit to show you one thing that's important. That's not too bad. Here we go. This is pretty good. You guys know what R wave progression is? Nope? That's crazy. There's a thing called R wave progression. Man, it's really, really important. In V1, the R wave, that's the upwards part of the QRS, should be almost nothing. And in V2, it should be just a little bit bigger. And then look down here in V3, it should be just a little bit bigger. And then in V4, should be the biggest that it is. And then in V5, it starts to get smaller. And in V6, it starts to get smaller. So this one's got good R wave progression. This one's got good R wave progression. Look at this one here. Tiny, bigger, bigger, bigger. This one's the biggest now. And then starts to get small again. Remember, the leads are determined by somebody who just put them on, who's not necessarily a trained person, very well trained. But this is pretty good R wave progression too, okay? So if you see the R wave in V1 like this, and then in V2, it still looks like this. And then in V3, it still looks like this. It's not getting taller. That's called poor R wave progression. And the computers will always call that anterior infarct age undetermined. Anterior infarct age undetermined. Every once in a while, I'll run across a computer program that will say poor R wave progression. But almost always it says anterior infarct age undetermined. And that's all it means is poor R wave progression. To me, it means absolutely nothing at all. It means absolutely nothing, but I know that you're supposed to look for the R wave progression, and I know that if the computer says anterior infarct age undetermined, it just means there's poor R wave progression. But this last one that we're looking at now, the ROE progression is kind of